You may have read a lot of CT angiograms for strangulation, but the yield of such a practice is unknown. Welcome to the AJNR podcast. I'm Francis Deng, the podcast editor and a neuroradiologist at Johns Hopkins. I'm glad to be joined today by my colleague at Hopkins, Dr. Jimmy Moon, the first author of a recent article entitled Utilization of CTA in Strangulation Evaluation. Welcome, Jimmy.
Hi, thank you for having me on this podcast with you.
So most of us have some idea of the screening framework that our referring clinicians have for blunt cerebrovascular injury, and it may differ from institution to institution. Can you give us some context here about when we may be seeing CTA next for the evaluation of patients who have had some trauma?
Yeah. So obviously, trauma is an extremely broad topic, and many institutions across the globe have their own ways and methods of triaging and evaluating these patients. We often have to trust in the judgment of our clinicians. However, there are some possible algorithms or suggestions that are utilized to triage these neck trauma patients, specifically what's noted as the Denver criteria.
Yeah, so let me go over what the Denver criteria are. So this is a paradigm for determining which patients who have had trauma require a neck CTA in order to evaluate for blunt cerebrovascular injury or BCVI. There are a number of criteria out there. There's the Denver criteria, there's the Memphis criteria, and many institutions have their own criteria. But this is one that's been endorsed by the Eastern Association for Surgery of Trauma, or EAST, as well as the American College of Surgeons. And it's also mentioned in the American College of Radiology's appropriateness criteria for spinal trauma. So the Denver criteria splits up the high-risk factors into clinical signs and symptoms, as well as those injuries that may be detected on the initial CT evaluation. So those clinical signs and symptoms that are considered high risk for BCVI include arterial hemorrhage, cervical bruit, expanding cervical hematoma, focal neurologic deficit, and neurologic examination that is incongruous with initial head CT findings. And the initial CT findings that we would report that would probably prompt a trauma surgeon or emergency medicine physician to then request a CT of the neck to evaluate for BCVI are the following. It could be a stroke on the initial head CT. It could be a Lefort 2 or 3 midfacial fracture, and certain cervical spine fracture patterns such as subluxation, fractures that extend into the transverse foramen, as well as fractures of the upper cervical spine C1 through C3. Any basilar skull fractures with carotid canal involvement, especially any petrous bone fracture, regardless of carotid canal involvement, as well as evidence of diffuse axonal injury if the patient has a low Glasgow Coma score, GCS, of less than 6. And then finally, we have one criteria that I never really clearly understood, but it's near hanging with agnostic brain injury. And that to me is the one criteria that is most closely related to today's topic of strangulation. But it's not exactly the same thing. What do you think about that, Jimmy?
Yeah, so I think the interesting thing about the Denver criteria as a whole is it does try to incorporate elements of the physical examination with imaging. So whether it be the symptoms or the imaging that comes first, the Denver criteria is definitely a necessary and an interesting way of looking at blunt cerebrovascular injury. The near-hanging part, like you alluded to, is what we were particularly looking at specifically for our study with the effect of strangulation on patients and the utilization of CTAs of the neck specifically for that one indication.
These Denver criteria, they've been modified multiple times over time, and institutions may have variable implementation of these criteria. In my anecdotal experience, people tend to image for a much broader array of reasons, and I think strangulation may be in that category. We see many strangulation patients who do not have clear agnostic brain injury, but may be undergoing CTA of the neck anyway. Mm-hmm. So that brings us to your paper, Jimmy. Can we talk about what exactly you did?
Yeah. So our paper was done corresponding 138 total patients in a level 2 trauma center located in an urban environment. We specifically looked at CT to the neck that was ordered with the strangulation indication. And then by going at a retrospective study, we looked back at the reports of these studies and these patients to see like exactly what were the rates of potential BCVIs or even other positive imaging findings that could be found on a CTA of the neck, including cervical spine fractures or other cervical spine findings or carotid injuries as well. And then we also looked at the presentation of these patients, including what kind of signs and symptoms they had on presentation and how it warranted getting a CTA for further evaluation.
Got it. So over a 5-year period in a retrospective review, you found 138 CTA neck performed for strangulation indications at this level 2 trauma center. Tell us what you found.
Yeah, so interestingly, out of 138 total patients, we found that only one had a BCVI, which was much lower than I was initially anticipating, and only two had cervical spine fractures. And interestingly, these were not overlapping. There were three independent patients in this study. So definitely, as a whole, much less than what I was anticipating. We also looked at, like I mentioned, the various symptoms and signs on physical exam that were also noted with these patients, which included things from neck pain, headaches, signs of strangulation, or neck injury on physical exam. But none of them really were more predominant than another, with the most common being neck pain at around 56% of patients who showed up to the ER with this history.
So 1 out of 138, that's a relatively low yield in this practice at this one institution of obtaining CTA neck for patients who have had a strangulation event. Now, let's show the one vascular positive case, because that's the best way to make this yield discussion real. So this is figure 1 from your paper that demonstrates an acute vascular injury. Can you walk us through this figure?
Sure. So we have A, B, and C, A showing an axial look at the CT angiogram, B looking at the sagittal view, and C is looking at a 3D reconstruction created of these images. The blue arrows are denoting the area where there is an abrupt cutoff in the right vertebral artery in this patient. And we can see the same thing happen across the axial and the coronal images. But I really do think that the 3D reconstruction that was created for this patient was really what helps to cinch in that diagnosis of this short segment area of complete occlusion or contrast opacification loss in this patient. And given what we utilize with the Biffle criteria, this would be for grade 4, the Biffle dissection.
Great. And as a practical matter, sometimes there's diagnostic uncertainty, whether someone has a traumatic vascular injury or there's artifact or congenital hypoplasia or underlying atherosclerotic disease. What was it about this case that made you guys or the original reader classify it as a true blunt cerebrovascular injury, BCVI?
Yeah. I think the one main thing to take away with this is that, like you said, there's a lot of confounders, but this patient was actually very young. She was a 31-year-old female, no other past medical history that would be a potential confounder, like atherosclerosis or hypoplasia, like you mentioned. And this kind of finding would not be considered normal in most people in that population. And then, of course, given the history, there was obviously an increased risk for neck injury, as we would suspect as to why they got the CTA in the first place. But the imaging findings being reproducible across the axials, coronal, sagittals, and 3D imaging, the reader and me as a reviewer was very confident in this being an acute finding.
Now let's step back to the numbers one more time. So among 138 strangulation patients who underwent CTA, you found only one BCVI, so that's 0.7%, which in my opinion is a relatively low yield. And it sets us up for the practical question, what do you think appropriate CTA use should look like in this population?
Yeah, I think that's the golden ticket question, Francis. So obviously there's not a true end-all be-all or catch-all symptom or finding that can best capture when a CTA of the neck should or shouldn't be used. I think from personal experience, and probably I would imagine most radiologists across the nation would agree, is that imaging volumes are going up. And that's an inevitable part of how our medicine has been evolving. So CTA to the neck are one of those things are inevitably going to be over-ordered for a variety of different symptoms. However, I think for now, still more research needs to be done to correlate what kind of symptoms can best help to differentiate whether or not BCVIs will happen, but also whether or not like things like the Denver criteria or maybe other criteria need to be studied in order to see what kind of correlations exist between BCVIs in the setting of strangulation or other related traumas. So for now, I trust in the clinical judgment of our trauma surgeons and our ER physicians who really assess these patients to the best of their ability. But I think from a radiologic perspective, we should prioritize those who have had either severe neurologic deficits or more severe trauma that's centered at the neck to get these CTs to the neck, hopefully to increase the yield that we clearly did not have in this study.
So I think this paper gives neuroradiologists and more importantly, emergency physicians and trauma surgeons some idea of the value of imaging that they're obtaining. And I hope that future iterations of the Denver criteria or other types of criteria for screening patients for BCVI are informed by evidence such as the one you generated for this paper in determining, which patients really need a CTA. Thanks so much, Jimmy.
Thank you so much for having me.
And listeners can find Dr. Moon's paper on the AJNR website in the February issue. Thanks for listening to this podcast. I'll see you next time.